Hello, I'm Professor Yang Seung-min. Successfully placing an implant is important, but more importantly, it needs to be maintained more carefully than natural tooth. Otherwise, it can lead to peri-implantitis. So today, we are going to look at the similarities and differences between the peri-implant tissue and the periodontal tissue, how to respond to the changes in the tissue, and let's have a look at it. First, this is the contents, periodontal tissue and peri-implanted tissue. We will compare them, how they are similar with each other and how they are different from each other. Next, when inflammation infiltrates into our body, how the peri-implanted tissues respond. Next, the biologic width is very important when it comes to the gingiva around implant, the significance of the width, and when it is violated, what kind of response can we expect, followed by response to inflammation in teeth and implants. We need to understand there are differences in the response to the inflammation, and we need to understand how to manage the situation. Lastly, summary. First, periodontal tissues and peri-implant tissues. If you look at here, both of them are photos, clinical photos of lower anterior. I indicated teeth and implant. The gingiva looks similar between those two in terms of the structure and the color surrounding the natural tooth or the implant. Outwardly, they look very similar. Let's have a look at inside of them. As you can see on the left, periodontal tissue around the tooth. On the right, peri-implant tissue. As you can see, there are structures in both of them. Let's have a look at that. In general, gingiva, periodontal ligament, cementum, and alveolar bone surrounding a bone or tooth. In natural tooth, we have all those four elements, but in implant, there are two missing. These two. PDL and the cementum are missing. There's only gingiva and alveolar bone. What does it mean? It means very important things. I will talk about it later, but in many cases, periodontal tissues and peri-implanted tissues, in terms of immune response to inflammation, would be different. And we need to look at the differences in the attachment of tissues. Let's have a look at it one by one. As you can see, a tooth and implant, around them, there are mucosal attachment. The mucosal attachment is different between the teeth and implants. Generally, when it comes to a natural tooth, as we know, circular epithelium, junctional epithelium, and the connective tissue attachment occur. Around the implant, we have the circular and junctional epithelium and connective tissue attachment. Individually, they look similar. However, if you look inside, there are some differences, and we will talk about that later. Mucosal attachment. When does it occur? It begins to be formed right after an implant is placed. So the important time is week 1 and 2 and week 6 and 8. And maturation occurs after that. At the beginning, proliferation of epithelium occurs. After that, the epithelium would be attached. So it plays the role of a barrier. So at the time of week 6 to 8, the barrier function is sufficiently established, and the inside, the collagen, the connective tissue, is formed at week 4 to 6 in the process of maturation. In the process, what if they get damaged before the mucosal attachment is formed? Can the attachment made properly? Generally, that is how it is being healed. From the placement of implant until osseointegration occurs, these days 2 months would be taken, that's enough, and we wait for the 2 months. What happens to the soft tissue during the period? As I said before, the maturation of epithelialization and maturation of connective tissue occurs. If biofilm occurs due to poor oral hygiene or inflammation, the formation would be damaged. So the first 6 to 8 weeks are very important for the barrier function to establish. We need to emphasize the importance of oral hygiene so that the barrier function is established. So we need to provide very strict oral hygiene instruction to our patients for the 6 weeks. The reason is around the implant, the barrier would be formed around an implant. I said the first 6 to 8 weeks are very important for the formation of the barrier. They are very similar between a natural tooth and implant. There is a difference in the height. However, the compositions are very similar. First, the epithelial attachment occurs, including the connective tissue attachment. Epithelial attachment is weak, and it is a connection to tooth or abutment by hemidesmosome. And the biggest characteristic of that is that it very well connected to outside. So if there is a colony of bacteria, various toxins from the bacteria can infiltrate into our body. That can happen because it has the permeability. If there is no permeability, we don't need to worry about it, but it is permeable, so it is important to keep that in mind. Connective tissue attachment is strong compared to epithelial attachment, and it is connected to cementum in a natural tooth or abutment of an implant. However, the resistance of connective tissue attachment is weak in implants. As you can see, natural tooth and implant, the attachment is formed similarly. However, the characteristics of the attachment is a bit different between those two. The most important thing is the barrier function of the epithelial attachment or connective tissue attachment. It's the barrier to external irritation. If the barrier is damaged, the stability would be unfavorably affected. How can inflammation occur around an implant? 600 or more bacteria exist in the oral cavity, and they form a biofilm, which is a habitat where bacteria can permeate with each other through channels. We need to understand how to manage the biofilm. Here, depending on the design or type of implant, for example, external versus internal type, or the connection type, flat top or internal connection may make some differences. However, in most implants, there are areas where inflammation occurs more. I said epithelial attachment has permeability. Permeability is found in the connective tissue or under epithelial tissue. Permeability leads to the infiltration of inflammatory cells. So it first appears below the epithelial attachment and between the implant and abutment connection area where connective tissue is attached. Depending on the implant type, the size of the problem can vary a little bit, but those two areas would be the vulnerable points. There can be many different implant forms. It can be 0.75 millimeters at the top and the same at the bottom, in total 1.5 millimeters. But the size can be reduced quite considerably. An external type implant can have an abutment smaller than the implant in diameter with a small platform switching, which is more natural with the internal type. On the right figure, on the left, it shows the distribution of inflammation when the diameter of an implant and the abutment is the same. The right side shows the distribution of inflammatory tissues when the abutment is smaller than the implant in terms of the diameter. Around the implant, what is there? Alveolar bone is there. Inflammation can infiltrate into the alveolar bone and then it will lead to the bone resorption. So inflammatory tissues affect the bone tissue. So if you look at here, when the abutment diameter is smaller than the diameter of implant, the inflammation can affect the body a little bit less. So that's the first difference. Let's look at the second difference. Around the tooth, gingiva fiber. You can see the types of gingiva fibers and the direction. Generally, dental gingiva fiber, dental periodontal fiber, and circumferential fiber, and transeptal fiber. So usually there are 4 gingiva fiber types, and they run in these directions. It's going upward, laterally, and downward. And the directions are different when it comes to an implant. The black portions indicate implants. And these are vertical sections. Viewed from above, they look like a circle surrounding an implant. That means in the vertical section, unlike lateral tooth, gingiva fiber runs in parallel with an implant. In the natural tooth, they were running in 3 directions, but when it comes to an implant, it runs in one direction. Some may run a little bit upward, but primarily in one direction. So if we go back to the previous illustrations, a tooth and implant, the gingiva fiber runs different directions. What does that mean? Fibers run in different directions when we do the probing externally. Lateral tooth has a resistance to the probe, so you cannot go deep. But when you do the probing around the implant, it can go deeper. That means during a healing period or during maintenance, we do the probing to check whether there is a lesion. Epithelial attachment or connective tissue attachment can be damaged by the probing. What happens after the damage? Healing will occur. So probing can be harmful as it damages the attachment that we need to be very careful of. According to a test, after implant placement during the healing period, if you do probing frequently, the attachment, epithelial attachment length can be made longer. Through probing, before attachment is established, it can be damaged and the pocket depth can increase. So probing around the implant should be avoided. This is very important when it comes to the tissue around an implant. Biologic width. When we say width, it means the width, but in a closer view, it means the thickness of gingiva around the natural tooth or an implant. So here, if you look at the same illustration, natural tooth versus implant, you can see the forms of gingiva. In a natural tooth, the epithelial attachment from the free gingival margin to sulcus, the length is indicated. The sulcus attachment does not exist, but as I said, is the thickness of the gingiva. So from the free gingival margin to the epithelial attachment. From below the epithelial attachment to connective tissue attachment. In a natural tooth, it's about 1 millimeter, and it is 2 millimeters around the implant. The connective tissue attachment is about 1 millimeter in a natural tooth and 1.5 in an implant, so their dimensions differ a little bit. It is a little bit thicker when it comes to an implant. Conversely, generally, so the thickness of gingiva, depending on that thickness, the thickness of tissue can respond differently after an implant is placed. So more detailed information will be provided later. The meaning of biologic width in implant, as I said before, is the soft tissue dimension. If it is violated or ruptured, soft and hard tissue stability around an implant may be damaged. So the biologic width depends on the different implant systems and surgical techniques, abutment types, and abutment roughness. Depending on designs of implants, there are 3 types. So in these 3 types of implants, the biologic width, as you can see in the pictures, there is variation. However, if you look at the overall length, they are more or less similar. From the gingival margin to bone, it's about 3.5 to 5 millimeters. It's around 3.5. So their dimensions are similar. The response differs depending on surgical techniques, whether an implant is submerged or non-submerged. Histologic and radiographic responses differ depending on implant types. There was a variation in radiographic dimensions, but as I said before, they are almost the same in terms of histologic dimensions. Conversely, we need to look at this. Small bone loss on the X-ray means the thickness is high. As I said before, from free gingival margin to bone, if bone loss is small, the thickness is high. So, depending on implant systems, there are variations. The biologic width of an implant can affect the stability of soft tissue and hard tissue surrounding an implant. The biologic width of certain dimension, it may vary from person to person. Some people may have it very thick and some thin. So, how does it affect the implant placement? When an implant, there are people with thick gingiva and some with thin gingiva. To accurately measure, it is important to measure it for each individual, but usually it is known to be around 2 millimeters. If that portion is damaged, like the picture on the left, from the bone to gingiva, it is 4 millimeters, but if it is reduced to 2 millimeters, what happens? Healing occurs, so the thickness of gingiva is 2 millimeters, and biologic width is around 3.5 to 4 millimeters, as I mentioned before. So if you place an implant in the thin gingiva of 2 millimeters, thinner than the biologic width in general, the bone response after placing an implant is bone resorption, so that the biologic width of 3.5 to 4 millimeters can be made. That means the biologic width is too thin, and if the biologic width that we want cannot be secured, our body makes some changes to accommodate that. So we need to understand what change would happen to our body, and we need to consider how an implant should be placed when the gingiva is thin and how we need to deal with that. So we need to check that and look back on these points before you perform surgery. You need to measure the thickness of gingiva at the surgical site. And one more important thing, Peri implant tissues and periodontal tissues. What's the difference in terms of blood supply? At the beginning, we talked about the structural components that exist near a natural tooth but not around an implant, and one of them is the periodontal ligament. In a natural tooth, around a natural tooth, most blood is supplied by PDL, which does not exist near an implant. So, the blood supply near an implant is much lower than a natural tooth. What does that mean? We need to understand the meaning of it. Below, it looks like very complicated coils between an implant and a natural tooth. This shows the supply of blood, the form of the vessels looks similar, but blood supply is much lower around an implant. If you look at the stained vessels around an implant, there is much less vessels on the left side. What does that mean? Immune cells go to inflammation. When there are many vessels, there are many paths for immune cells to reach the inflammatory area. So when external irritation comes in, it can be easily affected where the blood vessels are scarce. When a disease occurs, which one is better, prevention or treatment? Prevention is the best treatment. As I said before, when bacteria comes in, immune cells should go there through many vessels, and if there's less vessels, immune response cannot be made properly. So let's look at the response to inflammation. Response to inflammation. There's early response and late response. Early in the process, the response is similar in the implant and a tooth. So if you look at the histologic response, after 3 weeks, there is not much difference between the implant and a tooth, but there is a response difference if it goes on far too long, because around an implant, blood vessel is scarce, and natural tooth can defend itself with the blood vessels, but damage, destruction occurs more around an implant rather than defense. Even though the oral hygiene is poor in the same environment, the damage is slower in a natural tooth, but the damage is accelerated near an implant. So we need to keep that in mind. So for an implant site, we need to pay more attention to it in terms of oral hygiene. Summary. Peri implant tissue and periodontal tissue are distinct from each other, and there is similarities and differences in terms of structural characteristics, and we need to understand how the response is different between an implant and a natural tooth to inflammation. Understanding it will help you to maintain the peri-implant tissues better. One more thing, as I said before, the biologic width has about 4 millimeters of width. The width can be described as height, as I said before. It depends on the surgical technique, types of implant, and the types of abutment or its roughness. And we need to understand how peri-implant tissues would respond to inflammation. How was it? We looked at the characteristics of peri-implanted tissues to stabilize the tissues. In this lecture, we looked at and reviewed the peri-implant tissues so that we can increase the satisfaction of our patients when it comes to implant placement through regular visits of a dental office. Thank you for your listening.